Hi, good evening, everybody. Thank you all for joining us here today. It's my pleasure to welcome you to our lecture session tonight, where we have the honor of hearing from an orthopedic surgeon, Dr. Carrie Politzer. A few housekeeping items. We'll be recording today's session, so for those who couldn't attend us live, they'll be able to hear this lecture later. There will be a Q&A at the end, so please hold your questions at the end, and Dr. Politzer will be happy to answer them. If your questions weren't answered, we will have an email sent out later with how to view this session and how to schedule an appointment with Dr. Politzer. So without further ado, let's welcome Dr. Politzer.
Hello, everyone. I'm Kerry Politzer. It's a pleasure to be with you tonight. I'm going to share my slides and we can get started. Okay, so tonight we're going to be talking about hip pain and treatment options, pretty much a comprehensive guide. I'm going to try to keep it pretty succinct for you and so that we can get to as many questions as possible at the end. And so please, ideally, you can leave your questions until the end because I might answer them as we go along here. And I will do my best to cover everything, okay? Tonight we're going to start with my hip pain webinar with the lecture, and then again Q&A after that. You're not going to be able to talk during the lecture, but of course I look forward to meeting you in person, and we can discuss your specific issue in person in a clinic visit. The lecture is being recorded, as was mentioned, and you can find my knee lecture, knee pain and treatment options lecture in the same website, and I did that one back in May. So let's begin. First, a little bit about me. My name is Kerry Politzer again. I'm from Wyomissing, Pennsylvania. It's right outside of Reading, about 2.5 hours north of the DC area. And I went to Duke for undergrad. So, yes, I'm a Cameron crazy. Went to a lot of basketball games when I was there and had a great experience. Then went to New York for a year, but went back to med school at Duke. Just couldn't get enough of it. Then on to that's where I met my wife, who is an OB-GYN, and we went out to California for residency in San Diego. And then I did my fellowship in hip and knee replacement in San Francisco. You can see here at the bottom right of the screen, I'm part of OrthBethesda, which is a group, a multidisciplinary group underneath Aligned Orthopedic Partners, which is the overarching umbrella. So I know it can be a little confusing with all the names, but OrthBethesda is my primary group underneath the Aligned Orthopedic Partners name. So today we're going to be starting off with talking about hip anatomy and mechanics, just to understand the fundamentals of the hip and why you might be having pain. Next is assessing your pain. So the hip is a very complex joint. It's very deep inside, and there can be a lot of different pain generators. So we're going to talk about, where the pain is coming from and how we can determine that. We're going to talk about treatment options and exploring management options and total hip replacement, which is the bread and butter of what I do, and a fantastic treatment option for most patients with hip arthritis. And then recovery and next steps after surgery. And then again, we're going to finish up with a Q&A, and hopefully I can answer a bunch of your questions. All right, so I want to start off with talking about how the ball and socket joint works. So this is an image of a hip, and the hip is a ball and socket joint. It connects the femur bone to the pelvis and thigh, and so it has a large degree of motion. And it is made up of the femoral head, which is the ball, and the acetabulum, which is the socket. They both have smooth articular cartilage so that the joint can glide smoothly, but also there's synovial fluid, which is the lubricant in the joint that allows that to glide. Other structures around the hip include the hip capsule, the ligaments, and the muscles and tendons. And these all exist to keep the hip in the socket for stability, flexibility, to be able to move it in all different directions, and finally to power the hip and to power your motion. So let's talk a little bit about assessing pain. There's there's a lot of different reasons you might be having pain, and they can all present in different ways. This is super important to think about because when I'm thinking about a diagnosis or thinking about what might be going on, these questions really come to the top of my list to determine that. So, do you limp or have difficulty with daily tasks? Does pain limit your activities and lifestyle? And how? Do you experience balance problems, or are you a fall risk? Is there pain in the thigh, groin, or buttock? Determining where that pain is coming from is very important. Does it radiate down to the knee, or does it go down past the knee, down the leg? And does the pain keep you up at night? So figuring out these pain patterns, before you come into your visit can really help to tease out exactly where the pain is coming from. And sometimes, the pain is coming from multiple places. And so these are pain generators around the hip. This is again, the hip is very complex. And, the main ones I want to point out here, if you look at this green oval around E, the groin pain is often from inside the hip joint. So that's the most common place that I see hip pain in people with, as you can see here, hip arthritis, labral tear, and we'll go over these things in much more detail. The other Another very common complaint is I see people with lateral hip pain or pain over the side of the hip, and that's often from hip bursitis, which is also known as greater trochanteric pain syndrome, and we'll go over that in more detail as well. You can see there are a lot of different tendons around the hip that can cause strains and tendonitis. And if you look at the image on the right, you can see that large area of A, that buttock pain, that's very often related to nerve compression in the lumbar spine. But in more rare cases, maybe 1 out of 10 or so, that pain can be coming from the hip joint as well. So that's where a very focused physical exam and X-rays can come in handy to tease that out. So we're going to go over in much more detail the most common causes of hip pain, and I see these diagnoses all the time in my clinic, and so we'll go over what each one is, the symptoms involved, the various ways that I can figure out what's going on, and finally the treatment options for each one. And after that we're gonna focus on arthritis. So don't worry, we're gonna get to really delve deep into the arthritis side of things. But first, we're going to go over what I'm thinking about when I see a new patient in clinic who has a diagnosis or has a complaint of hip pain. So this is osteoarthritis is an extremely common complaint and problem. We're going to go over that in much more detail shortly, but what it is essentially is the wear and tear of the ball and socket joint, where the cartilage can get worn down, and that can lead to various manifestations in the hip, like bone spurs and bone cysts and a lot of pain in the joint. It can lead to clicking and catching, and those are things that we're going to talk about. So the symptoms mainly include deep groin pain, stiffness of the hip. So you may notice that, over time, you're not able to move the hip in as far as you used to. Maybe you can't go crisscross applesauce anymore or things like that. This usually is worse with activity. So at the end of a long walk, or maybe you can't walk as far, or upstairs, and usually is associated with some stiffness in the morning. Usually, the exam features include limping, sometimes some decreased range of motion, so pain on internal rotation. Occasionally, there's crepitus or catching involved, and X-rays are going to show an asymmetric loss of space in the hip joint, usually right at the weight-bearing surface of the hip, but there are different manifestations there. MRI is not needed to diagnose hip arthritis when it is more severe. Sometimes MRI does show that there's more cartilage wear than the X-ray demonstrates, and that's where MRI can come in handy. But most of the time, if it's very severe arthritis, MRI is not needed. And we're going to go again into treatments much more in depth for the arthritis side of things, but very, broad overarching non-surgical treatments aim to decrease pain and inflammation, and surgical treatments aim to remove arthritis, and we'll get into that shortly. So next is avascular necrosis, or AVN. That's also known as hip osteonecrosis or femoral head osteonecrosis. And what it is the head of the femur can lose blood supply from a number of reasons. Most of the time, we don't understand why, but sometimes it's associated with steroids. Sometimes it's associated with alcohol and or trauma. And and that can be very painful. And so you can have a normal X-ray with AVN that can be very, very painful. But as you can see on the X-ray on the right here, the femoral head is actually collapsed, and that causes a lot of pain and basically simulates arthritis and can cause, the cartilage to come off or wear down off the head and also off the cup, and can be very painful. So the symptoms are mainly similar to arthritis, but mainly groin pain. It's worse with weight bearing, where the head is starting to where the head doesn't no longer has blood supply or is starting to collapse. And in later stages, there's also night pain associated with that, and that can be a trademark symptom. So features here: limping, decreased range of motion, similar to arthritis. But one thing is that sometimes the exam seems pretty normal, but there's way more pain on weight bearing than you would expect, and that's pain out of proportion. And we talked about the risk factors. The X-rays sometimes are normal, but sometimes in more advanced stages can show arthritis with femoral head collapse. And an MRI, especially in the earlier stages, MRI may be needed to verify the diagnosis, or perhaps it may be masquerading as something else, maybe a soft tissue injury or something that's not getting better, where MRI then reveals the severity of the problem. The treatments here include both non-surgical and surgical again. The non-surgical options aim to decrease pain and inflammation, again, to give you, and we'll get into that again in a little bit, in a bit for the arthritis side of things, which is the same here. And then bisphosphonates are the only medication that have been shown to slow the progression or stop the progression of AVN in certain cases. Surgical options include either cord decompression, which is only an option before you see any collapse on X-ray, and it could be a good option for a very young patient with AVN. But basically, if AVN occurs a little bit later in life, then the cord decompression option becomes a little bit less palatable, because you do need to be non-weight bearing on that side for a long time, and the success rate is not super high, probably around 70% or so. And so you start talking about doing a total hip replacement instead, and we'll go over that later. The next topic here is acetabular labral tear. The acetabulum, again, is the cup of the hip joint, which is the ball and socket. And you can see on the image here, the labrum is the soft tissue ring that goes around the head and holds the head in place. It it prevents any micromotion of the head. And so when there's a tear, sometimes that the head can have a little micromotion, and that can also be a pain generator in the hip. The symptoms are mainly sharp groin pain in young and middle-aged adults. Usually we think of this, we think about this more as a soft tissue injury and not as a degenerative problem, because When labral tears occur, like when there's degeneration with like arthritis, it really is not the pain generator. It's the more the arthritis that's the problem. Whereas when there's no arthritis, the labral tear becomes much more important. And it can cause catching or clicking. It can also be, you might notice when you're twisting or pivoting that you have much worse, kind of severe, sharp pain, deep pain inside that groin area. The features here, again, pain or catching and clicking, mainly on flexion and internal rotation of the hip. But X-rays are usually negative, but there are certain developmental issues that can lead to a higher chance of having labral tear or labral problems. These things mainly include things like femoroacetabular impingement. That's a fancy way of saying, hip impingement. And impingement is basically bone contact with bone. And so what that is where there's an extra bump of bone around the neck of the femur or around the cup that causes decreased motion and causes the bone to hit against the labrum and can cause a labral tear there. That's usually developmental and increases during adolescence. Hip dysplasia is a kind of the opposite problem where the cup doesn't go over top of the head as far as normal, and so there's more stress on the labrum because there's not as much bony stability. And so the head is pushing on the labrum, and the labrum is trying to keep the head in the joint, but it can tear because of the increased stress. So in these cases, an MRI may be needed if the initial treatments are not working. And the initial treatments include things like physical therapy to increase your core strength and stability of the hip. Other options include NSAIDs to decrease inflammation, and most of the time, labral tears do improve without surgery. But in kind of severe cases that go on for a long time, and I'm talking, usually 9 to 12 months, or if it's a very large tear, the arthroscopic surgery may be needed. And again, we're talking mainly in people in their 20s to 30s, sometimes into the 40s. And this arthroscopic surgery would include usually repairing the labral tear. So taking the labrum, tacking it back down on bone with suture, and removing any extra bone that might be causing that impingement or the bone hitting onto the labrum and maybe causing the tear in the first place. And that's called osteoplasty. So another very common complaint or very common issue I see is hip bursitis, and that's also known as greater trochanteric pain syndrome. And so if you look at the image on the left there, the bursa is the greater trochanteric bursa is the kind of light bluish soft tissue over the side of the hip bone, which is yellow, between the hip bone and the iliotibial band, which is white. And when that soft tissue gets inflamed, like you see on the right side of the image, which is the left hip in this image, it becomes inflamed and red, and it can be very, very tender to the touch over the side of the hip. And so typically the symptoms are lateral hip pain. It's worse when lying on the side or crossing legs, and it's worse when walking or climbing stairs, usually. And the features that I look for are tenderness right over that side of the hip, usually in the back side of the greater trochanter, which is the side of the hip. And sometimes I see more pain when asking you to rotate your hip outward, and I resist that, and that tends to activate that area and bring the IT band down to the bursa, causing pain. And MRI is usually not needed for this unless it is a again very severe or very chronic case where we need to start thinking about other factors, maybe like the hip abductors being a factor. The treatments here mainly include modifying activities to avoid the things that hurt, and usually the bursitis can calm down. Other things include physical therapy to strengthen the muscles around the hip joint. and NSAIDs like ibuprofen or Aleve to decrease the inflammation there. Lastly, and this is something I do very often with great success, is a steroid injection into that area, into the hip bursa, right where it's painful, which can really eliminate that hip pain fairly quickly within a few days. And sometimes it can last for 3 to 6 months, sometimes much longer. So sometimes I give, a couple injections, but usually I don't, it resolves before giving, more than two or three. Another common issue here is muscle or tendon injury. And there are lots of muscles and tendons around the hip joint, and there can be injury to any one of them or inflammation. So tendonitis, you may have heard of. And so this image shows the all the muscles and tendons in the front. There's also kind of all sorts of layers of muscles and tendons in the back as well. And so that's where a very focused exam comes in to try to figure out exactly which muscle or tendon is the issue, or where the issues are. And a lot of these tendons are right near the hip joint, and so there can be it can be difficult to figure out whether the pain is coming from inside the hip joint or one of the tendons. And so the main symptoms here are acute pain, especially if there's an injury or a fall, and that stretched the tendon or tore the tendon. There can be pain over a specific area. It can be tender to the touch, and cramping, spasms, and tightness in that area are common complaints that I see with this. Again, you might have tenderness right in that area, maybe some swelling and bruising because there are blood vessels around the tendons that can bleed if there's an injury. There can be pain with resisted hip motion in that direction. And x-rays are usually negative. If the tendon pulled off a little bit of bone with it, sometimes I see a little speck on the x-ray. That's less common, but that's why we usually get x-rays, and to make sure that there's not a fracture or any other issue with that injury. And finally, an MRI may be needed if the pain is not improving in a reasonable time frame. Usually, we expect it to start getting better within 2 to 3 months. But these things, just because they're not surgical most of the time, does not mean that they are not a nuisance and can be quite painful. The treatments here include rest to allow it to heal, at least for the first week or two, and then starting physical therapy to keep your motion around the hip and to allow it to heal in a way that is that gives you a lot of good longevity and reconstitutes that tendon and muscle. And NSAIDs for decreasing your inflammation. And finally, steroid injection only if that would be after an MRI, maybe just verifies that there's a tear or a partial tear or tendonitis that's just not responding to any other treatments. But that's a little bit more rare that we would do a steroid injection for this problem. Lumbar nerve compression is one of the most common hip complaints I get, believe it or not, and that is because it's another kind of masquerader. When there's compression of a nerve in the lumbar spine, and you can see on the image on the right here, that the lumbar, or I should say the nerves exist in the center and come out at each of these levels on both sides, on the left and right, and go down the legs. Now, the nerves can get compressed either in the middle of the lumbar spine due to movement of the vertebrae or spondylosis, which is arthritis of the vertebrae, causing bone spurs that pinch the middle of the nerves, or they can get compressed on the way out before they go down the legs. And that's what you see here. So there's a herniated disc at this top level here that is that's compressing the nerve. There's bone spurs here on that second level compressing the nerve. Or it can also be compressed from arthritis or facet joint hypertrophy in the back, as you can see here. But that is a very common issue. And the most common symptoms I see when there's nerve compression in the spine, believe it or not, is actually buttock pain. And that's kind of what I was alluding to earlier when I showed you the picture of the pain generators around the hip. The buttock and posterior hip pain is kind of the hallmark or trademark of nerve compression in the lumbar spine. Sometimes it radiates down the leg, and that's called sciatica. It's usually worse with standing or sitting for a long period of time, or sometimes it's positional. Like it's worse when you're standing straight up, but not as bad when you're leaning forward. The key features here are tenderness, or increased muscle tone to the buttock, and so and that's why I do palpate the buttock area to see what if there is a lot of tightness in the buttock muscles, because that can indicate to me that there might be a nerve getting compressed. There's usually normal hip range of motion as long as there's not also hip arthritis. And sometimes you see, both problems together. Sometimes there's neurologic symptoms like numbness, tingling, or weakness, although that's much less common. And x-rays may show some degenerative problems in the lumbar spine, like where the discs start to wear out, become closer together, or where there are bone spurs that may be impinging on the nerves. And an MRI may be needed if the initial treatment options are not working. And so the initial treatments are physical therapy, and the main thing is core strengthening around the abdominal muscles to stabilize the lumbar spine. NSAIDs like ibuprofen or Aleve can help with the inflammation, and basically continuing low impact activities and exercises. But if these initial things aren't working, then sometimes an MRI is needed to take a closer look at where there might be nerve getting pinched. And then one of my spine partners would be talking to you about doing a steroid injection in the epidural space to decrease that inflammation around the nerve, and that can be very effective. Or sometimes, if it's more severe, or if the injections aren't working, or something to that nature, spine surgery may be warranted. Now, I'm a hip and knee surgeon, and I'm happy to see anyone with any hip pain, of course. But if you think you might have lumbar nerve compression or spine issues, it may be better idea to see one of the spine surgeons first, just to kind of cut to the chase there. But I manage a lot of kind of initial management for lumbar spine, so I'm happy to see you either way. This is so now let's delve deeper into arthritis. Let's take a deeper dive. And so this is arthritis is very, very common. Over 67 million adults will have arthritis by 2030 in the United States alone. And 1 in 4 people will develop symptomatic arthritis in their hips in their lifetime. So it's the leading cause of disability in the United States. And as the population ages, the impact on quality of life and healthcare costs do continue to go up. So this is a very important problem and something I'm very, very passionate about, as you may tell. The um, the hip joint you can see here, in this X-ray on the right side of the screen. The left side, or the right side of the image, which is the left hip, has good joint space between the ball and the socket. The right side of the image has very severe arthritis where there's no space left between the ball and the socket, which is known as bone-on-bone arthritis. You may have heard. Basically, you can think of it like if you have tires on your car and the treads are very thick when you start, but when the tire first is purchased, but when it wears out, it becomes bald and becomes like bone-on-bone arthritis, where there's just no tread left. There's cysts, and there are little dark areas in the bone where cysts are in the head, and that bright white around the hip is hardening of the bone called sclerosis. And so there's a lot of information that I can get just based on on one single image on an X-ray that can basically tell me what is going on inside the hip in terms of how advanced the arthritis is. Let's talk about risk factors for hip arthritis. And some are modifiable and some are not. Obesity is a modifiable one, potentially. Obesity increases the joint load and causes increased inflammation throughout the body. There's also metabolic factors that are kind of associated with obesity sometimes, but things like diabetes, high blood pressure, hypertension, or high cholesterol, which is called hyperlipidemia, they all can increase your inflammation as well and change the cartilage and cause the cartilage in the hips and knees to wear out. Genetics is a non-modifiable risk factor, but hip arthritis does have a strong heritability, meaning if you have family members like parents or siblings who have hip arthritis, then you're more likely to have it as well. And in some kind of more severe cases where there's a collagen disorder like Ehlers-Danlos syndrome, those folks are at higher risk of arthritis as well. There's issues or developmental abnormalities can lead to arthritis, like we talked about dysplasia, hip dysplasia, where the the acetabulum or the roof over the ball does not go as far. And so it puts more stress right over that area where you're weight bearing, and that can increase the risk of arthritis there. There's also femoroacetabular impingement, again, where there's that extra bump of bone, which can cause stiffness, but also leads to earlier arthritis in some cases as well. The possibility of hip injury or avascular necrosis or AVN. So if there's a fracture or a dislocation, that can decrease the blood supply to the head, or it can also shear off some cartilage or injure the cartilage and lead to degeneration in the joint. And then a non-modifiable risk factor is age. And so after the age of 50, it is a much higher risk. The average age, for context, the average age of hip replacement and knee replacement is 69. So I know that was kind of a whirlwind, but now we're going to switch gears again. We're going to start talking about the treatments for hip arthritis. And just a reminder, if you can try to hold your questions until the end, because I'm going to, go over some of the things that you might be asking yourself. So starting, there are kind of three areas of interventions that we can do. Non-pharmacological, meaning interventions that do not involve medication, pharmacological interventions, and surgical interventions. So the non-pharmacological interventions, and we're going to go over all of these in a lot more detail, but as a brief overview, include activity modification, walking aids, icing, physical therapy or home exercises, low impact activity, and weight loss. The pharmacological interventions include oral medicine like Tylenol or acetaminophen, and NSAIDs like ibuprofen or Aleve, or prescription versions of these things, and a joint injection of cortisone, which is a steroid. And finally, surgical interventions such as hip arthroscopy, hip resurfacing, and total hip replacement. Although now that total hip replacement has become so effective with such a high satisfaction and low complication rate, and it's lasting such a long time, these other options are becoming less and less appropriate, especially if there's any arthritis for hip arthroscopy. But hip resurfacing, which you may have heard of, like Andy Murray, I believe, had it done, and so it can be appropriate or thought of for a very young individual. But now that the plastic and total hip replacement is lasting so long, it's really very rare that that I would recommend hip resurfacing anymore to anyone. All the evidence that I'm going to provide today is found partly here in the clinical practice guideline. It's free to the public at the website found at the bottom of the screen, aaos.org/OAHCPG2. And you can download it and look at all these things for yourself and all the evidence and data out there to support these findings. So let's start with talking about the non-pharmacological interventions. So the first step in thinking about treating hip arthritis is avoiding activities that hurt, and that's activity modification, or also putting less pressure on that painful hip, especially if you notice that you're starting to have balance problems because you can't rely on that hip. It is important not to fall, especially as you're getting a little bit more elderly, perhaps, and with poor bone quality, we want to always prevent falls. So a walking aid may be right for you. The next step is icing. So icing over the top of the hip or the side of the hip, whatever is, wherever you're having the pain to decrease that inflammation and swelling. Physical therapy or home exercises. And, I'll always give you that option. Some people really do well with a coach telling them exactly what to do twice a week and keeping them on track. Other people are very self-motivated or um, prefer just to do it all on their own, which is fine as well. But the key is consistency and strengthening the muscles around the hip joint to keep that hip locked in, prevent it from and to stabilize it and keep it mobile and prevent pain. Finally, low impact activity is very important as well. So continuing your walking, other options if you have access to a gym are cycling, elliptical, or rowing machine. If you have access to a swimming pool, you can go swimming. But these are all very good options to decrease that impact on the hip. So, people ask about running or tennis, those are less ideal, especially if you have hip arthritis. But if you do these activities, the key is limiting your exposure and limiting your mileage, for instance, if you're a runner. So next we'll talk about weight management, which is, it can be very difficult, but worth it in many cases because every step you take, your weight is going through that joint. And so even maintaining your weight can be very useful for helping to decrease your hip pain. So when thinking about weight management and how to lose weight, the keys are, of course, nutrition and exercise, and want some options, some pharmacological options like Ozempic, although I don't have any financial ties or anything to that company, but any of those GLP-1 agonists are fine. You can talk to your primary care doctor about that if you are having trouble with the nutritional aspect of losing weight. But the key is preserving your muscle. And so think about high protein in your diet. So shifting calories away from the high fatty foods, and simple carbohydrates, and toward the higher protein foods with lean protein. So that includes things like fish and chicken and turkey. And the reason is because the you want to maintain your muscle mass, and especially if you're having trouble moving, to improve your strength and balance and hip function. And healthy weight loss goals include aiming for weight loss of about half a pound to 2 pounds a week. It's much more sustainable that way instead of having kind of big drastic changes in your weight, which can result in malnutrition, believe it or not. And the target is overall weight reduction of about 5 or 10% for significant health benefits, for cardiovascular benefits, but also to benefit your hips and perhaps knees and lumbar spine. The optimize, and it's also important when considering when you may need surgery either soon or much later on. you want to optimize your nutrition because when in people who have higher weight or higher BMI, especially over 40 to 45, we see higher complications, higher risk of problems with the implants, and with infection. And the other thing is insurance may require a BMI limit for hip replacement, although if it's bone-on-bone arthritis, that usually is not the case. Talking about opioid, now we're going to go into the pharmacological treatments here. So non-opioid pain relievers include Tylenol or NSAIDs. Acetaminophen is a pain reliever and fever reducer. It acts in the brain, so it is not an anti-inflammatory. It does not decrease inflammation in the joint, but it can help you get through some of those tough days. And again, Tylenol is the brand name for that. NSAIDs can be a very useful tool to help with kind of prolonged pain relief with decreasing inflammation and overall. And over-the-counter examples include, again, ibuprofen or Aleve, which is naproxen. There's also aspirin is an NSAID, but it is also a blood thinner. So I do not recommend that for pain relief. It can cause, you to get bruising and it's not recommended, for this reason. Prescription examples of NSAIDs include diclofenac, which a lot of my patients find very effective. And it's a little bit more pain relief than with your ibuprofen or naproxen. Meloxicam and celecoxib are both very good options as well. Of note, if you're on a blood thinner, you should not be taking NSAIDs. And there are other reasons why your primary care doctor may tell you not to take NSAIDs, and I would respect that. Oh, so for the vast majority of people, opioids are not a good option for chronic pain relief, especially in arthritis. There are exceptions, if there's if there's an injury that causes a very severe pain that's not relieved by other pain medicines, opioids are an option for a short period of time, for a couple of weeks maybe. Or obviously after surgery, opioids do play a big role, or can play a big role, but they are not recommended. And that includes even the weaker ones like codeine and tramadol. We try to avoid because they are habit forming and they actually can increase your sensitivity to pain if you take them for a long time, for over a couple of months, and also your reliance on them. And so I do not routinely prescribe opioids for hip arthritis. Injections are an option for hip arthritis, and they kind of come in a couple, or the reason to do injections is for a couple of reasons, but we'll talk about it then in a second. So a steroid or cortisone injection is the only injection inside the hip joint that has been shown to be effective for pain relief in the longer term. Now, the other options that are good for the knee have not shown benefit for the hip. So that includes hyaluronic acid, which is the gel injection, PRP, which is platelet-rich plasma, and stem cell injections are not recommended by the American Academy of Orthopedic Surgeons or the American Association of Hip and Knee Surgeons because the evidence does not show benefit. Imaging is required to do this injection, although I do it routinely in my clinic under X-ray guidance. Another option is ultrasound guidance, and Mark Bruner is one person in our group who does these under ultrasound guidance. But they can be done, at the same clinic visit as the diagnosis. The reason to do it is for twofold. Obviously for pain relief, and that pain relief can be for up to 3 to 6 months. Although I will say it's usually a little bit not quite as long as the pain relief that we see with knee cortisone injections. And it can be but sometimes it can be very difficult to figure out exactly where the pain generator is. Is the pain coming from inside the hip joint, or is it coming from the back or somewhere else? And so it can be a very useful tool to diagnose whether the pain is actually coming from inside the hip joint. It is covered by insurance and can be given up to every 3 months. But in the hip joint especially, I do recommend waiting 6 months usually if we can. Let's start talking about total hip replacement. So this is the surgery for hip arthritis, and it's total hip replacement, not partial hip replacement. Hemiarthroplasty or partial hip replacement could be an option if there's a fracture of the femoral neck or the hip, but for arthritis, that's not an option. It's also known as hip replacement is also known as hip arthroplasty. The implants reduce the damaged joint surfaces, and the goals of hip replacement are to relieve your pain and restore your mobility and function. Oftentimes, people do come back after 6 months or a year and say they forgot that they even had the hip done. That's not all the time, but it can be that incredible of a surgery. This is an idea of what a total hip replacement looks like. It involves a metal cup in the acetabulum or the cup inside the cup of the bone with a plastic liner. And then on the femur side, you have a metal stem with a ceramic ball. So the new joint then becomes ceramic on plastic. This is another view of what a hip replacement looks like. Again, arthritic hip on the left side of the screen with the implant components being the metal stem, ceramic ball, plastic liner, and metal shell. And these are implanted on the right side of the screen. And these are the um, top of the line, and basically 90% of the time, 95% of the time, the implant materials that I use, which the metal is titanium for the bone to grow into it. Sometimes if the bone quality is very poor, you can cement the stem into place in the femur. And so that's just one minor variance, but that's very, very rare. This is an X-ray showing a hip replacement. On the left side of the screen, you have very severe arthritis with decreased joint space and basically bone-on-bone arthritis. There are some bone cysts and bone spurs throughout the joint. And then on the right side of the screen, you see the hip replacement, which did a very good job of putting the metal cup in a good position. The screw is in the bone. Now, not everyone uses screws for all their hip replacements. Some use it selectively, like myself, but and then looking at the metal stem is in a good position, and so that's a very well done hip replacement. So now I'm going to show you and narrate an animation. If you have any squeamish, it's not bloody or anything, but if you have any squeamishness, might not be the best thing to watch, but it is just an animation here, just to give you more of a flavor of the direct anterior approach to the total hip. And I do probably about 98% of my primary total hips from this direct anterior approach. There are reasons to do it from the posterior approach, which we'll go over next, but this is kind of the workhorse. So the patient is lying on their back. Go through the muscles, not into muscle. To take out the capsule and remove the femoral head, and then prepare the inside of the cup. Place the metal cup and put in a plastic liner. And then on the femur side, put in a brooch, which is kind of preparing the metal canal or metal part, and then putting in the final metal stem. And I'll just let you kind of watch that again. I know it's fast. I couldn't figure out how to slow it down. And the x-rays again are used during the surgery to make sure that everything looks like it's in a good position and exactly how I want it. And that's one big benefit of the anterior approach, is that it's very easy to get x-rays a few shots during the case to make sure that I'm very happy with where the components are sitting, and that makes you happy as the patient after surgery. The um, the other thing is I use artificial intelligence to make sure that your legs are perfect length and that that I recreate your anatomy as perfectly as possible. This is the post-year approach, and so it's a little bit different, more of the quote-unquote traditional approach. But there is still some big indications to use this approach, and it works very, very well. I think a lot of people are, kind of gets a bad rap, but a lot of people are surprised by how quickly they can recover using the post-year approach as well. And there are many surgeons who this is their primary approach, and I think, when it comes to deciding which kind of approach you want, it really will come down to what that surgeon is most comfortable with and what they recommend for you. So this is for a left total hip, and the patient is lying on the side. And just as a side note, you'll notice that this is actually for a femoral neck fracture. I couldn't find any videos of just for arthritis. So lying on the side, the incision is done on the side of the hip, and so the tendons do need to come off. I repair them at the end, and basically, again, same thing. Prepare the cup, put in the metal cup and the plastic liner, and then prepare the stem as well and put in the final components there. And at the end, repair the tendons back down. So that's the big difference between the two approaches. The direct anterior approach, you're on your back. I go through the muscle layers rather than detaching the muscle off the bone, which you have to do in the posterior approach. So the question, when am I ready for a total hip replacement, comes up a lot, and only you can make that decision as the patient. You should consider surgery if your hip pain or dysfunction, like stiffness, for instance, affects you every day, if it prevents you from doing activities that you enjoy or want to do, and if it prevents you from getting a good night's sleep, because all these things decrease your quality of life. And there is a solution that 95% of the time will give you a better quality of life. There are other things to consider in the kind of calculus here. So early diagnosis and treatment are critical to deciding when you want to do hip replacement. The longer you wait, the longer you have a bad hip, and the shorter you have a good hip. So that's called opportunity cost, because the sooner you do the surgery, the sooner you can get back to doing the things you enjoy, and the less time you need to spend with a hip that is bothering you. So delay can also make the surgery and recovery more challenging, depending on the severity of arthritis. If it's extremely severe arthritis, that can make the surgery harder, and that can make it a little bit of a more difficult recovery, or it could require you to maybe go from one approach to a different approach. There is up to 95% rate of patient satisfaction after total hip replacement. So let's talk about what surgery looks like. It depends on if you're going to have surgery at the hospital or surgery center, but you'll arrive about 2 hours early. Hip replacement itself takes about an hour and a half. Physical therapy will get you up after surgery. You're walking on it, you're doing stairs, and practicing before you go home. And most people go home the same day. Even if it's done in the hospital, most people go home the same day. And this is a change from, say, hip replacements done even 5 years ago or 10 years ago, where nearly everyone was staying at least one night and sometimes 2 nights. But what we found is patients actually tend to do much better when they're at home and they're able to sleep in their own bed and they're able to get up whenever they want and move around. Because in the hospital's for sick people, and nurses are used to that, and it's no fault of the nurses, but patients tend not to be able to get up out of bed nearly as much as they can at home. Reasons to consider having surgery at the hospital instead of the surgery center include if you have medical problems or a high BMI, or basically obese, severe obesity. If you require an assistive device preoperatively, that could signify that you're weak and may need to stay overnight to do more physical therapy in the morning. If you don't have help at home, that could be an indicator that you should at least stay one night in the hospital just to make sure that you're safe to go home. Now, what does that mean? That could help at home really just is having someone you can rely on who can check in on you a couple times a day. People don't have to stay with you in your home, but as long as you have the food that you need and someone is aware that you just had surgery and able to check on you and basically make sure you have your needs met is very important. If you have chronic pain issues, that could mean that you may have trouble controlling the pain after surgery. And so that's another reason we would maybe keep you in the hospital overnight to make sure we are on a good pain regimen before you go home. And then finally, if you have a history of difficulty urinating, you need to be able to urinate before going home. And so that's a situation where doing surgery at the surgery center might be a little more challenging. Rehab after total hip replacement, the first couple of weeks you are doing in-home physical therapy most of the time. That includes just light exercises, walking with the walker, working on gait mechanics. The physical therapist will look at your home, make sure that all the fall prevention precautions are being addressed and that you're safe in your home. Your focus should mainly be to recover. It doesn't really require a whole lot of work on your part after a hip replacement. It's mainly just getting up and ambulating safely with a walker, just working on gentle flexibility, but nothing crazy, elevating the leg, icing the hip, and pain control, which mainly includes Tylenol and a combination of Tylenol and NSAIDs like Celebrex for baseline pain control with your opioid, which is either tramadol or oxycodone, as needed for if you have pain on top of that. Later rehab in the weeks following surgery, basically you're starting to do more distance in the first couple weeks, more stairs. Home exercises are done. You're starting outpatient physical therapy at about week 2 to 3. And then in weeks 4 to 6, you're starting to walk more and extended distances, doing more household chores, resuming your activities. By week 4, you're able to start driving, sometimes a little bit before that if it's the left hip. And you're starting your advanced strengthening by about week 7 to 12. And I do not expect it to be a straight line in the healing direction. Very often, I see people have kind of a roller coaster type of healing, which is totally normal and okay. But basically, you want to continue to do advanced activities when you're ready, but without overdoing it and maybe having a setback. A lot of questions that I see about the surgery, about hip replacement. So does it hurt? It does. The first 2 weeks are usually the worst. And we do have multimodal pain control regimen for you. Early mobilization is key, physical therapy. And the other thing is hip replacement. Often people say it was easier than they thought, or it hurts much less than a knee replacement. And so those are all very important things to understand. We talked a little bit about the recovery timeline. Immediately, you're able to walk and do stairs. You can shower immediately, just let the water run right over the dressing. You can return to work at about, on average, 4 weeks. Now, if you have a very labor-intensive job where you're on your feet all day or a lot of walking or lifting, it may take a little longer than that. Whereas if you work at home or have a desk job, basically the recommendation is just as long as you're off the opioid pain medicine, you're able to go back to work. And some people go back within a week or two, but that's the exception, not the rule. Returning to driving, I mentioned about average 4 weeks if it's the right hip, sometimes a little sooner than that if it's the left hip. And you're usually fully recovered by about 3 to 4 months. That's an average. Some people feel more recovered sooner than that. Some people can take 6 months to feel like they're fully recovered or longer. But most people who come in at that 3 month visit say they're very close to being fully recovered. A lot of people ask, are there restrictions of motion? Like, is there instability? Are they going to dislocate their hip? After an direct anterior approach, the risk of dislocation is very, very low. It's about 1% or less. And there's actually good recommendations and good data showing that providing recommendations after doing a direct anterior hip replacement or providing precautions, I should say, is not recommended. That being said, I do test stability during every surgery, and if I feel that the stability is not perfect or exactly what I want, I may provide precautions in that situation, but it's very, very rare. Now, for a posterior approach, that is a different story. It is a higher risk, about 2 to 3% of risk of dislocation or instability of the hip. Most surgeons would always provide precautions after a posterior approach. But you should talk to your surgeon about that. But the precautions include no combined flexion, adduction, and internal rotation. And physical therapy will make sure that you understand that before leaving the recovery room, if that is the case. So we talked a little bit about which approach you should have, and my recommendation is to go with the approach that the surgeon feels is best for you, or that the surgeon is most comfortable with. Both approaches have been found to have equal results and satisfaction after about 3 months. So in my hands, or in my what I've found in my hands is that the direct anterior approach provides a little bit of a quicker recovery. And again, that decreased dislocation risk. But posterior approach is absolutely a great surgery. And I still do the posterior approach in some cases where that it requires that. So how long will the hip last? The good news is by 20 years, there's over 80% survival, meaning no of the hip joint specifically of the implant. And so that means the risk of needing another surgery within 20 years is less than 20%. And so what I tell patients is that I expect this one surgery to last you the rest of your life. Now, for younger patients who are less than the age of, say, 60 years old, we can't really predict that far because the plastic liner that we use now, it has been around for about 30 years, and we see virtually no wear at 30 years. But we can't really predict what it's going to look like in another 20 years. So for the most part, it's a very safe surgery. It's a very long-lasting surgery, and for most people will last the rest of your lives. And so just to summarize before we get into all the questions, I see the questions are starting to come in. The leading cause of hip pain in elderly patients is arthritis. But again, there's a lot of different pain generators around the hip, and so that's the first task when I see you in clinic. The focused history and exam can determine where that pain is coming from. Arthritis is degenerative, meaning it won't get better, but it may get worse. Early diagnosis and treatment are very important, and many non-operative and operative treatment options exist. And so I'll go over those with you in clinic when I see you. Total hip replacement does have a very high satisfaction rate, over 95, about 90, up to 95%, which means that it's not 100%. About 5% of people are not satisfied after surgery, but it's a very extremely high rate of satisfaction that you really can't find in any other surgery, I would say. And so we'll help you get through this every step of the way. For more info, you can go to hipkneeinfo.org. It's a wonderful website for patient interface with the American Association of Hip and Knee Surgeons. And click on the hip care link, and you'll see a lot of information about your hip health and the information that we went over tonight, as well as information about hip replacement. So there's a lot of good information there. Again, I'm Kerry Politzer. I am a fellowship trained hip and knee replacement surgeon here at OrthBethesda, which is under Aligned Orthopedic Partners. You can see my contact information at the bottom of the screen, and I would love to see you in clinic. So let's. I see we're running really out of time here, so I apologize about going over. I'm going to try to answer some questions here for maybe about 10 minutes until 7:45. Please feel free to exit if you have to go. But I again apologize about not getting to a lot of questions, but let's get into some questions. Okay, so the so a question about buckling and locking of the knee. Okay, never mind. Let's go to a different question. So someone asked about hip replacement risks for people who are overweight and morbidly obese. So the risks there are mainly have to do with infection. So there is a higher risk of infection. Now, we use antibiotics before surgery and maybe a short course of oral antibiotics after surgery. There's also the possibility of wound complications and issues. And I would say, over a certain BMI, doing the hip replacement from the direct anterior approach becomes very challenging and basically reduces any benefit that you would get from doing it that way. So that in those cases, posterior approach is what I use, and people do extremely well with that for the people who have for certain people who have very high BMI, and they do very, very well. Other risks include, hip dislocation, loosening of the implants, and mainly those kinds of risks are the ones that you would think about for obesity. There should be no restrictions to movement in around your hip, and we talked a little bit about restrictions after hip replacement. If it's a posterior approach, usually I tell people there are restrictions for the first 3 months while the scarring, while it kind of scars in. But after direct anterior approach, again, I don't recommend any restrictions or precautions for hips. In terms of designs for artificial hips, um, there are different designs, but they're pretty much all kind of going toward one direction at this point. But there's kind of the primary hip replacement, and then a whole different discussion would be about revision hip replacement. If you say you have a loose stem, or if there's an infection and the components need to come out and new components need to go in, there are different types of components that we use for those situations. But for the primary hip replacement, I found that in 95 or 98% of the time, I have extremely good results using the kind of most common types of implants. There's a question about plane travel after hip replacement. How soon can you fly? So, generally speaking, you shouldn't be sitting in one position for over, say, an hour and a half. After in the first month after hip replacement. So I generally tell people you should wait to fly if it's over an hour flight, including, and then an hour and a half, including taxiing and whatnot, or unforeseen circumstances, that it's probably safer not to fly, but if you have to, make it less than an hour flight in the first 30 days. After that, the risk doesn't go down to zero of blood clots, but the risk goes down to the average risk. And so still important to get up and walk around every couple hours, just like you might if you didn't have the hip replacement. There's another question about if you lost mobility due to arthritis, can you get some mobility back after hip replacement? And the answer is absolutely yes. You can get a lot of mobility back, a lot of mobility back. You may not be so the hip replacement, it is metal and plastic and ceramic. And so there are limits to kind of what the implants are designed for, depending on how it's put in and everything. But it usually is a lot more motion than you have if you have very severe arthritis. The stem that goes into the femur is about this size, the size of my a little bit longer than the width of my palm. So it's about 12 to 14 centimeters about. And it usually does not cause the metal detector to go off in the airport. But if it does, they'll just wand you and you can walk right through. You don't need a note or anything like that. Someone asked about exercises on a 24-inch box. You are going to be able to do step ups and step downs. I would recommend against doing a lot of high impact activity after hip replacement. Now it can be, it's not forbidden. If you love doing these box jumps, you can do it, but just understand that you may be putting more wear on the plastic liner than you otherwise would be doing, and so the lower impact activities tend to make the artificial hip last longer. But running and tennis and jumping activities are not prohibited, but you just need to understand that you are risking potentially wearing out the plastic liner faster if you do that. The metal in the hip replacement is always MRI compatible, so you can absolutely get an MRI after any type of joint replacement. Someone asked about replacing both hips at the same time. I have done that. I do that infrequently, but at times in certain situations it can be done. The main kind of things, if I would say it can make a more easier surgery turn into kind of a very difficult one. But in the right patient, and if you have limits on how much work you can take off, or if you're very young and motivated and strong, those are reasons that you could consider getting both hips done at the same time. Um, Someone asked about osteopenia, osteoporosis. That's a great question, but so poor bone quality, like osteopenia, osteoporosis, is not at all related to hip arthritis. Arthritis is just wearing of the cartilage in the joint and the associated inflammation around that. And so you can have a patient with very bad bone quality with perfect cartilage and no arthritis. And you can have someone else who's a very young patient with concrete hard bone uh, who has just very severe arthritis. So really no change there. It just if you do have very severe osteoporosis, meaning the very bad bone quality, again, I may choose to use cement to fix the stem in place in the femur rather than press fit. Okay, I think we're coming on to the end. Maybe one more question. There is a question. Let's see if there's another one here. There's the rest of the question. There's a question about bone loss going to be corrected with diet and exercise, or maybe they're talking about cartilage loss. Um, Diet, exercise, good nutrition and exercise can make your hip feel better and decrease the pain, but to this day, we don't know of any disease modifying medications or activities. So that means we can't put the cartilage back. We have no way of regenerating the cartilage or reversing the arthritis issues. But the good news is we do have a very overwhelmingly successful surgery to address it when it gets to that point. And I think I'm going to stop it there because I'm sorry I didn't get to all the questions. Those are some great questions. But I'd be happy to answer any more of your questions in person. If you have a very specific question, you can also direct it to this email address here, politzerma@alignedortho.com. But if you have multiple questions, or if you wanted to get us if you wanted to get a professional opinion about your own situation, I would love to see you in clinic at either in the Bethesda office at OrthBethesda, or in the Tyson's office at Greensboro Boulevard, which you can find the addresses on the website. But it was a pleasure speaking with you today. Thank you, everyone.
Thank you so much for Dr. Politzer. This was a great presentation. I learned a lot from it. As he did mention, we are recording and this will be uploaded to YouTube, and then it will be emailed out and on our website. So if you have free questions, if you want to book an appointment, everything will be in the email. Thank you so much. Thank you, Dr. Politzer. Have a great night, everybody.
Thanks, everyone.
Bye-bye.